at the Department of Psychiatry and in the Center for Depression Research and Clinical Care at UT Southwestern in Dallas, Texas. And I'm here to guide you through this session on precision medicine. So we have a great lineup of speakers, and I'm not going to take any time. Remember to use Slido if you have questions. So that's the method of which we're taking questions. And we're going to start with Paolo Fuserpoli, who's going to start our session talking about psychosis. Oh, I'm sorry. I didn't do affiliations. So Paolo's from King's College London and also is affiliated with the University of Pavia and LMU Munich.
Thank you. Good morning. Buongiorno a tutti. And I've been asked to talk about advancements in the application of precision psychiatry in early psychosis. These are my disclosures. And as clinician, I work in prodromal psychosis, trying to prevent psychosis in people at a clinical high risk. So that's what I'll be focusing on. We are all familiar with the clinical high risk model, so we don't need to go through that. But just quickly, we are focusing to the clinical high risk stage. The phase basically preceding the first episode of psychosis. We are looking at young persons aged 14-35 who presented some disability, functional impairment, and mild attenuated symptoms that do not yet reach the diagnostic threshold for a major episode of psychosis. And that's a kind of the first window of opportunity for implementing prevention in clinical practice, even in the NHS. And the first step for implementing preventive psychiatry is to detect the problems presenting by these young persons. They are so-called attenuated symptoms, attenuated positive psychotic symptoms. They're so-called unusual experiences, and these are Instagram drawings made by our patients. And unusual experiences like hearing things other people don't, seeing things other people don't. These experiences, again, they are subtle. They are not severe or frequent enough to meet diagnostic threshold for a major episode of psychosis, but they are associated with a very high risk of developing the disorder. So we need to be able to detect them with a good accuracy, and then to predict the outcomes. And that's where precision psychiatry and recent methods can be very beneficial. Because so far, the way we've been attempting in detecting this feature was just using leaflets, outreach campaigns, websites. This is the website of the clinical service where I work, Oasis, in South London. We try to promote access to care, access to preventive mental health support for young persons. This is all good, but we are still missing many young persons. So we thought of embedding a digital screening system which is based on precision psychiatry to be more effective in detecting early psychosis, the prodromal phase to psychosis. And this is an ongoing program called ENTER, e-detection tool for emerging mental disorder, funded by Wellcome Trust, which is run in King's College London, University of Glasgow, and more recently also in other European countries. And our idea was to implement a digital screening program based on precision psychiatry for young people living in the community. So we are specifically looking at the community. So the first step was to implement an outreach campaign targeting different social media, Facebook, Instagram, local colleges, universities. These are kind of the recruitment number, the number of those assessed in both London and Glasgow, and try to outreach and to approach young persons with possible emerging psychosis. And the way these digital screening methods works is here illustrated. So these young persons, they are invited to complete a short assessment on their app, on their mobile, which is based on very short assessment of psychopathology, an automatic analysis of their speech, and a very short assessment of their cognition. And then there is an algorithm which is based on a previous publication, analyzing this data and formulating an individualized estimation of their likelihood of being at risk for developing psychosis. So, and if the algorithm is detecting a possible risk for developing psychosis, then The research team receive an alert, and then we try to contact the individual and then to recommend a further fine-grained assessment for psychosis risk, a remote assessment, psychopathological assessment with gold standard established assessment tools, such as, for example, the CARMS, the comprehensive assessment of at-risk mental state, and so forth. So this program has been quite successful, and then we are further refining the algorithm to simplify it and to make it shorter, even more accessible, and hopefully this will help us to improve our ability to detect many young persons who may be at risk of developing psychosis in a very efficient and cost-effective way. This is kind of a way of implementing precision psychiatry for detection of emerging psychosis in the community, but we also try to complement it with similar approaches targeting the secondary mental health care, so people who are already under the care of mental health services for other reasons. For example, you know that psychosis is a transdiagnostic phenomenon and may originate from, for example, a depressive condition. There may be young person presenting with depressive disorders and then receiving support from a certain mental health services, and then after a few years developing maybe schizophrenia. So in the trust where I work in South London, the trust is paper-free. We only have electronic health records, and clinicians, they input their clinical notes in the electronic register. Therefore, we thought of embedding, implementing precision psychiatry algorithms to screen these records and potentially detect those who may be, again, offered a full assessment for psychosis risk. So we developed a very simple risk calculator which was based on available predictors in the local electronic health records. It was a Cox model including sociodemographic factors that are epidemiologically associated with the onset of psychosis, and the index diagnosis, like, for example, initial diagnosis of personality disorder or depression, who then later on could predict the onset of psychosis. We also then tried to refine this method, this approach, with a more sophisticated algorithm, risk calculator, using the natural language processing app, which are present in the local electronic health record. The natural language processing is a data mining technique which is based on machine learning and artificial intelligence to basically dig out very specific symptoms as written in the clinician's notes. For example, we could extract features like presence of irritability, appetite loss, exposure to cannabis or cocaine use, insomnia, feeling of guilt, and so forth, with a certain accuracy. And then we can use this psychopathological information at index when the patients they access for the first time the NHS trust to forecast, to predict the onset of the likelihood of developing psychosis in the future, and therefore to make an individualized prediction of outcomes. The algorithm is then capable of individualizing the prediction of likelihood of developing psychosis from 1 to 6 years and quantifying that, and then that's quite useful for the clinicians, as I will show you in a while. The next step for us was to try to replicate this approach. Replication is essential in psychiatry and in precision psychiatry, as I will demonstrate in a few slides. And this is the original performance, the performance of the original algorithm in South London, in Lambeth and Saddock. The accuracy, the RLC was 0.8, which was not perfect, but was okay. This tool is, can be deployed to screen thousands of patients in one go. It's cheap, it's passively screening data, and therefore it's ideal for a first approach. And then we try to replicate the tool in another 2 boroughs in South London, and the accuracy survived. Then we further replicated it in Camden and Islington. Interestingly, the accuracy here was lower, but in Camden and Islington, the trust did not have any preventive clinic, but still the calculator showed some promising accuracy. We also then stretched the calculator and tried to replicate it in the US. There was huge case mix, and here the accuracy was lower, and further in Oxford. And this was the basic version of the calculator. When we refined the calculator using natural language processing, so a bit more fine-grained prediction based on the notes made by the clinicians and artificial intelligence data mining techniques, the accuracy internally and externally was substantially improved to 0.85. And we further pushed the calculator, trying to refine that with a dynamic version, which does not just predict the likelihood of developing psychosis at baseline, but upgrade it over time. And this was published a couple of weeks ago in Biological Psychiatry by our lab. And the red line shows the prognostic accuracy of the dynamic version of this risk calculator, still using natural language processing over time and compared to the static version. And then the RLC was boosted up to 8.87 or 87, which is quite interesting. So we developed precision psychiatry screening methods for the community, for psychosis risk for the community, for secondary health. What we were missing was something for primary health care. And in order to meet this aim, we partnered with the industry, in this case with Lundbeck, and then we further developed a risk detection screening method called DETECT, and we tested it in the US, IBM Exploris database. In this case, we used we fitted a neural network model, which is artificial intelligence-based algorithm, and this database is including about 15% of the US population. In this case, predictors were based on availability, and again, this calculator collected the predictors in a kind of dynamic fashion. This algorithm also showed good accuracy as externally validated. The accuracy level was 0.8, and the right part of the figure you can also show the so-called dynamic the decision curve analysis, which basically estimates the potential clinical utility of using this calculator to screen young people at a risk for psychosis in primary care compared to standard detection approaches. And the results of this estimation suggested that it has potential clinical benefits. So it could be potentially useful in clinical practice. The program went on to try to implement these tools in clinical practice because, as we know, and that's basically the hot potato in this symposium, many risk calculators in psychiatry are developed. Few of them are validated internally, even fewer are validated externally, and when it comes to implementation, that's a systematic review we conducted a few years ago, less than 1% of all algorithms in psychiatry, not just in psychosis, is implemented. So most of them, they're not used in clinical practice. So we tried to collaborate with clinicians, with the patients. We developed an interface, a digital interface, which embedded our risk algorithms to screen the local electronic health records and then to produce basically the outputs, those who were above threshold, those who were basically possibly at risk for psychosis, their basic characteristics, and so forth. And then we tried to implement these calculators in the NHS, and we piloted it for a few months and conducted one of the few implementation study of precision psychiatry approaches. And that was the outcome. We deployed a governance pathway for using precision psychiatry in the NHS. We had a good clinicians and patients endorsement. We screened thousands of individuals in few months. And the primary outcome of this implementation study was how clinicians and patients adhere to the recommendations made by the calculator. Because even if you have the most accurate risk precision tool, but then clinicians and patients are not happy, do not want to use it, then still the tool will be useless. And we found that about 70% of clinicians were adherent to recommendations made by the calculator, and with a bit of outreach, this proportion was increased to 85%. I'm going to conclude with future perspectives. We are now refining these algorithms with new prediction avenues for bipolar disorders. There are available in recent instruments such as the semi-structured interview for bipolar risk state, which allow us to predict not just the first episode of psychosis, but also the first episode of bipolar. There is an associated training if you may be interested, and we are trying to enrich our existing precision psychiatry tool, which are engineered to predict psychosis only, towards a bit more transdiagnostic prediction, which is also including prediction of first episode of developing bipolar disorder. We are also involved in a large international study called ProNet from the AMP Schizophrenia Consortium, which is trying to deep phenotype about 2,000 individuals at risk for psychosis, with a wide array of modalities: neuroimaging, cognition, EEG, genetics, psychopathology, digitomics, and hopefully this would further boost our ability to not just predict an individualized outcome, but also implement it in clinical practice. And to advance this field, we are collaborating through this Prevention of Mental Disorder and Mental Health Promotion Network, which is meeting this afternoon and trying to advance research in this field, and obviously funded by ECNP. And thank you very much for your attention.
Thank you very much, Paolo. So we have some questions coming in. The first question relates to the Enter e-detection tool, and how does it take into account ethnicity and other biases that might be present in some of the machine learning approaches?
Thank you. It's a good question. The tool is co-developed with the experts by experiences, and so the patients, and ethnicity is one of the predictors, but it's not the only one. And we've done also work trying to remove the predictors and to see whether the algorithm was still surviving and it is still effective.
And do you see any risks with screening and assessing psychiatric issues in a community sample?
Yes, of course. I think this will be the topic of the next talk.
Right. Do you think this can be implemented when resources are stretched so much already? So, from an implementation more generally, what do you think the barriers are?
Yes, the digital screening is very cost effective if obviously implemented in an ethical, sensitive approach. But still at the end, once you detect someone who's at risk for psychosis, you need to offer some support in terms of clinical support, pathways to care. So at that stage, still some clinical infrastructure would be needed, like, for example, preventive clinics, like the Oasis where I work.
Okay, last question. For studies predicting psychosis with about 80% accuracy, how was the accuracy of the instrument defined in the context of a higher frequency of negative versus positive status?
Negative versus positive?
Yeah, so I guess the...
I'm not sure I understand the question correctly. The accuracy is the RLC I shared with you. Above 0.5 is just beyond chance, and for a risk algorithm to be considered for implementation, it should be certainly above 0.8, if not 0.9. There are not many algorithms reaching these thresholds, but importantly, the algorithm should be validated externally and to demonstrate that they can be transported in different scenarios, not just in the data where they have been developed. And this is why we've done a lot of external validations attempts in different NHS trusts in London, with different socio-demographic composition, as well as outside London and even in the US.
Okay, great start. So we'll move to the next talk, and we have Mirko Mankia from the University of Cagliari. That's great.
Thank you all. Good morning. It's a pleasure to be here and to talk about some of the ethical implication of the application of precision psychiatry. This is my conflict of interest, but before starting with the talk, there is the need of a premise, a foreword. All this work, most of this work, stems from the joint efforts of two European College of Neuropsychopharmacology networks, the Network on Bipolar Disorder and the Network on Prevention of Mental Health and Promotion of Health, led by Professor Ole Andreasen and Professor Paolo Fusarpoli, which joined efforts in creating a European brain research area cluster on severe mental disorder. And the main topic, the main agenda of this cluster was to work about implementation of precision psychiatry, starting from the ethical challenges and then focusing on how actively implement precision psychiatry, not only among clinical care operators, but also by involving all the relevant stakeholders. And this was done with two-step procedure. One was the workshop that was held during COVID, so it was an online virtual workshop on February 2021, was a consensus exercise which included all relevant stakeholders such as bioethicists, philosophers, of course oncologists, psychiatrists, people with lived experience of mental illness, as also family representative of people living with experience of mental illness. So this led to the production of a white paper, which was published a few years ago, and that describes basically the ethical consideration that needs to be included in the implementation of precision psychiatry. But what is precision psychiatry? It's simply an approach that changes paradigm and goes beyond the one-size-fits-all that is common in traditional medicine and arrives toward a personalized approach. Although personalized can be considered a misconception in terms of terms, precision psychiatry allows to describe that the therapeutic or diagnostic or screening approaches that are dedicated to a specific individual are actually not necessarily different from one person to another, but they may be common to shared groups of patients, and in this case we talk about stratified precision psychiatry. So basically, at the core of precision medicine, there is the development of an individualized prediction model that is applied to a specific individual and has diagnostic, prognostic, screening, and treatment implication. This is a great step that can be reached only by the integration of diverse sets of data, as clearly stated by a paper in 2021 from Francis Collins, former head of the NIH. This work can be led also only through the gathering of data that come from large longitudinal cohorts of patients followed up for many years. And this is the only way, having longitudinal with multiple time points data, in which we can really have the possibility of gather statistical inference for testing our hypothesis with sufficient robustness, but also includes aspects related to the inclusion of minorities into this large database, of course via the integration of multi-modal approaches that include machine learning and deep learning even more so, that by integrating genomics, clinical data, phenomics, and also environmental predictors of mental health, or also mental illness, of course, can actually create new taxonomies of conditions that can be identified with specific signature of risk. This is a step that can be reached only toward the integration of diverse sets of layers, as we can see here. And when we talk about integration of diverse sets of layers, we talk about digital monitoring data, cognitive assessment, brain imaging, genomics, phenomics, transcriptomics, which can be then modeled and toward the specific algorithms that include the adjustment for heterogeneity, for instance, among centers recruiting in a specific study, and also the convolution approach can actually inform transparent risk prediction, but also inform mechanicistic development of a specific condition. This means that we can also use precision approaches to identify potential new target for drugs. And of course, this will lead to more effective clinical trials and in the end inform in a much more accurate manner also clinical guidelines and eventually transform clinical care. So in synthesis, what we see is the importance of a multimodality of approaches and data that are used to predict the specific outcomes. That comes also especially with the integration of biological and phenotypic data. Of course, accurate phenotypic and biological data. And this should lead as a third step to improve predictive performance that, of course, can have important implication for the people who underwent precision psychiatry approaches. So, in psychiatry, we cannot avoid the personalized approach, because assessment of a patient who has a severe mental disorder is based on clinical psychopathology and the analysis of the phenomenology. This is strictly related to the subjective of the person and means a strictly personalized approach. The problem is that even if the foundation of psychiatry are personalized and to some extent along the line of precision medicine or precision approaches, they are still not yet sufficiently precise because they do not include, as of yet, or not extensively, the role of more biologically oriented data. So, even having in mind these challenges, it's important to note that the presence of application of precision psychiatry approaches has to face several barriers. One of the most important barriers is actually stigmatization, because stigmatization, personal or public stigmatization, can impede people living with severe mental disorder to access precision psychiatry approaches, which have an important value, not only clinically, because they lead to more effective treatment, but also have an important value in reducing the emotional burden related to the trial and error approach commonly used in medicine and in psychiatry even more. This is something that is not only related to the implementation and integration of data for improving effectiveness of treatment, but it's really an approach that can increase quality of life of people suffering from mental disorder, severe mental disorder, and also for family living with people with lived experience of mental disorder. So, in this context, it's really crucial to develop a specific ethical framework that can be applied to these novel approaches of precision psychiatry. Just as a specification, I'm not a bioethicist, I'm a clinical clinician, I'm a psychiatrist, I work with patients with severe mental disorder, especially mood disorder. So it's quite clear how the disorders impact on the trajectory of life, especially when they start, as Professor Fusaspori was showing, in the early life of the subject, in the transition from adolescence to young adulthood. But the fact is that there are no ethical blueprints, and there is the need of integrating the data that are coming from new studies on prediction of development of mental disorder and also prediction of treatment response in specific population in a way in which the algorithms are fed with correct data, not discriminatory data. This, of course, is related to the fact that not all people have equal access to care, and precision psychiatry is going to be costly. So this could actually increase the gap of access for people who have no support in terms of economic access to healthcare, specifically in countries who are less developed economic status. Of course, if this aspect remain as a constant, the data that are gathered from for feeding the predictive algorithms tend to be or could be eventually crystallized in terms of wrong prediction. So we have a pattern of bias that tend to be included into the predictive model. In turn, this could lead to a design of the predictive model that are not effective. There will be also the possibility that the testing practices become biased, and in the end, we can have the impossibility of really decide or really assess whether this specific intervention in terms of precision approaches could be effective, could be cost-effective compared to standard of care. And clearly, if people have difficulty in access digital instrument, or there is no resources to access, for instance, digital monitoring tools, which are key in precision psychiatry approach, this could deepen the digital divide. So this is a concern that we need to have in mind, and when we developed the workshop, we wanted to learn also from the field of medicine, which have already been successful in implementing precision psychiatry approach. Certainly, oncology has been one of the leaders in this, and from that we try to develop a blueprint with specific cases, and we focus mainly in identifying the ethical challenge and then propose a specific solution. Probably the key point in mental health is the communication of a mental health risk. This is something that could be really a perilous task, especially when people who are subjected to the prediction of a specific the risk of developing a mental disorder could be in the early phase of their life, and they may have many concerns in terms of the impact on their life trajectory, but also on their career trajectory. Not to talk about also insurance problems that are coming even more in light in this last couple of years with the development of this predictive algorithm. So this is why there is the need of establish a multidisciplinary governance framework to promote the reflection and also the discourse on the interaction between what is the prediction of risk for that specific patient or for that specific subgroup of patients and the reaction of the human that are subjected to the prediction. Not all the people, not all the patients would like to receive, for instance, an update or specific details on the risk prediction based on their specific clinical and neurobiological characteristic. This is not the same traditional approach in which there is one directional transmission of communication from the physician to the patient. Here there is the need of a specific disclosure that should be shared between the healthcare operators, competent, trained, educated in transmitting these specific and very critical messages, and of course the people living with the severe mental disorder. Another aspect is that risk of communication can be quite complex, not only in terms of impact of risk estimate, but there are really scant data on how communicating a specific risk to, for instance, develop a psychosis in a couple of years, derived on precision psychiatry algorithms, could in fact also perturbate the neurobiology that is present and underlies this data that we have used to produce the prediction. So this is really a key point that still needs to be investigated thoroughly, and more research is certainly needed in terms of how to disclose properly this communication. So I will just do two practical use cases to see how ethical challenges are always present when we decide to communicate a risk estimate. And of course, the communication of risk estimate does vary from age group. Certainly the communication of risk in an early phase of the condition or even in premorbid phase is different from a condition that is communicated with risk is communicated at a later age, for instance, in terms of neurodegenerative disorders. But even so, the implications are substantial. Let's see this recent work from the group of Nicolas Koutsoulairis. They were able to utilize neuroimaging data together with other clinical data to develop an algorithm that predicted the outcome for schizophrenic patients at 1 year in terms of recovery. Well, patients who had schizophrenia, but also showed that there were some signature, some imaging, some fingerprints in the brain imaging of frontotemporal dementia in their behavioral variant in the neuroimaging had actually a much worse course of recovery at 1 year, meaning that some specific neuroimaging characteristic can really lead to a prediction of how the patients will be able to recover. And maybe this should be patients that need to be more intensively followed up with maybe cognitive remediation or use of drugs that can actually be more actively at a specific area, neurobiological area that improves neurocognitions. For instance, memantine or other drugs acting at the glutamatergic system. So in this case, we have a type of risk communication. If we talk about what, from an ethical point of view, we are doing, the impact of the risk estimate on life trajectories is probably not that high because the disorder is probably already established. Still, we have elements that the relevant elements that the prediction gives to the person and also to the clinicians about the trajectory of recovery. So there is room for improving healthcare based on this prediction, and certainly is important for decision making if we think about also the possibility of deciding what to do in terms of end-of-life decision. So these are not negligible aspects. And another example, the final example, relates to a very recent paper that you probably most of you have seen on Nature, which is quite striking, and see how the salience network tends to be enlarged consistently. This was a data related to precision mapping, neural precision mapping using fMRI, triplicated in 3 independent cohorts, which see that the salience network is enlarged in people who have depression, but not only in people who have affected by depression, but also in people who recover from depression, so in euthymia. And this specific enlargement of the salience network, which is involved in elaboration of reward processing, but also conscious autonomous feedback elaboration, this is also present in children who are not ill, so who are not suffering from depression, but they, at this point, are at risk of developing depression. So this means that the type of risk communication is much more demanding, much more important. The risk estimate on life trajectories has several implications. I already mentioned what these are, especially also on the impact that this diagnosis could have on career or life expectancy of development. So there is also an important relevance for prevention and decision making, because in these cases probably prevention is key, especially in the first years of life. Once this is established, that is a valid biomarker for identifying people at risk for depression, to maybe implement cognitive behavioral therapies even in childhood and in adolescence to decrease the impact of these specific risk markers, neurobiological risk marker. There is also a lot of work to do in terms of stigmatization. Privacy issues are crucial because people do not want to be labeled as a risk for at risk for developing a severe mental disorder such as depression. And certainly disclosure preferences are key. People should allow to have their ability, their freedom to decide whether to have receive a decision or not. So with this, I thank you for your attention. I hope I, in some way, highlighted some of the main concerns that precision psychiatry is leading now in the field. Thank you.
Thank you. Thank you. So there's several questions coming in, but I'll just ask one, which is related to health economics. So are there predictions of how this could be successfully applied from a health economics perspective? But also one of the questions that I think is really interesting is in other countries or low-income areas where there's not the access to electronic health records, what do you think the starting point is for those sort of approaches for people in lower-income areas?
Well, probably that implies that we need to focus on these countries in terms of fundings, created this program, and probably also trying to develop. There have been some examples on this. I've seen grants on, for instance, implementation of genetic assessment, like thorough genetic assessment of other population to gather genomic data, large-scale genomic data, for instance, in Pakistan. And this is important not only to implement precision psychiatry, but also to facilitate trans-ancestry analysis. So we need to go toward the Caucasian model and implement all the data in our algorithms. And this is something that, for instance, the PGCBD, the Consortium for the Genomics of Bipolar Disorder, has been doing in the past years.
Great, thank you very much. Okay, so we'll continue on, and we have Ole Andresen from the University of Oslo, who's going to continue the conversation.
Thank you. Thanks for organizing this great seminar. And I will, here are my conflict of interest. I will have a bit of another approach, starting with more nationwide data and also trying to focus on multimodal data. But I'm starting with the same conceptual paper that Mirko showed. And what is quite important here is that this is now being built in other parts of medicine, but I think it's equally important to do precision medicine and psychiatry. And I will give you some examples why this is important, that we don't step out and let other disciplines do this type of work. And there's also one important factor here is what I will focus on is the large Nordic samples and also the privacy and trust. I think this is really important, that like what Mirko talked about, that if we are going to make this happen, we really need to focus on stakeholder input and people with lived experience. So, but we are moving now into big data, how we can develop these prediction tools to stratify treatment, to find the right treatment for the right person. And there we need to go into the real world data, as Paolo showed really beautifully in the English health trust systems. But we have also been working on this in the Nordic region, building a pipeline, a system for developing precision medicine. And here we are really focusing on mental illness. And here you can see we have then big registry data, nearly 2 million people, where we have biobanks and e-health records, the records for the registries in the Nordic countries. And we can then, we're focusing on the severe mental illnesses, combining with RCTs, and then see if we can predict treatment response, because that's where we see the largest potential. And as you know, this is really an arena for artificial intelligence, train the models and test them in different new samples. And in Norway, we have now quite a lot of large population samples, as you do in the UK. And we have also a birth cohort of more than 100,000 children who are now getting to the age where they develop mental illness. And this is something it's a bit of infrastructure here, but the opportunities in the Nordic area is to combine biobanks with hospital samples and then develop these kind of distributed analysis across the Nordic countries. And this is something we have now, we've been doing it. I think it's important with, you can't share data, you need to keep them in each hospital trust or each region, and then use something called federated learning. Then you can send the analytical tools to the different databases without sharing, because it's really important that we don't know the kind of identity of the people involved. And why, what is the challenge with mental disorders in this area? If you have cancer, you can find a tumor, you can find a specific genetic variant, but the challenges are that the diagnoses are overlapping. There's a lot of comorbidity. As Mirko said, even though it was exciting finding in this Nature paper, there are very, very small multiple effects on the brain and also on genetics. So here you can see the heritability of mental disorders, and that is why can we use genetics to improve this precision medicine, and that's a major part of moving into precision psychiatry. So there's been a revolution. I will just briefly mention it, that it is now, technology is changing medicine, and this is really now, at least in Norway, where it's expensive to park. So this is getting very cheap now. So then it's shown that you have with all these, there are massive amounts of data out there with 100,000 of samples. And what we see is that the genetics of mental disorders are highly polygenic. It's not one gene for schizophrenia or depression. Many, many small effects. And I just want to illustrate this with everybody here. I presume have heard about genome-wide association studies that you do a lot of genotyping on many, many patients with a disorder. It could be 100,000, and then it could be 1 million people without. And then you really have a large sample where you can test many, many genetic variants. And this is schizophrenia. Each dot here is a variant, and the higher you get, the more significant. And we see it's not one gene, it's 270 genetic variants. Bipolar disorder, this is now recent data, nearly 300 loci. And also Alzheimer, which I will show a bit about also. There are some genes with high effects, but now there's also a polygenic picture. And that's why people have now started developing polygenic risk score. Combining all of these variants, can you just add all the 300 and see, even though each of them have very small effects, if you put them together, can you then predict? So could there be some kind of a threshold in risk, inborn risk, in these heritable disorders? So can this be used to predict disease? This is something we've been working on to improve the prediction performance, and it's not really high. Even though we have all these variants, our best, if you add 20,000 genetic variants, you get like 11%. So there is not yet any clinical useful use of these polygenic tools. I was in a meeting here, we're discussing, is the time to do polygenic risk scoring in psychiatry? No. It's promising. So this is something we are also working on now. If there are different, I think Paolo received this question, are there different predictors in different samples, or this is what we've shown in that the genetic architecture are different. This is in clinical samples where you where you have people in a clinic hospitalized, and you interview them. Then you have community, everyone in the community with a diagnosis, and then you have self-reports. And this is in bipolar 1 and 2, large sample, 50,000, 120,000 in total. And you see the genetic overlap. This is a Venn diagram. It's quite big between clinical and community. But the self-reports are outside. So people saying, I have a mental disorder, this is bipolar, have a different genetic architecture compared to the clinical. But it's a large overlap also. But the community, that's also included in the clinical. But then bipolar 1 and 2, bipolar 2 has more genetic variants than bipolar 1. But then bipolar 1 is mainly in the community, but bipolar 2 is somewhat outside. And you can see that bipolar 1 is very few are inside the self-reported, but bipolar 2 are more in the community outside, where people have milder forms of bipolar disorder. So in order to make these prediction tools better, you need to know what kind of, where you're setting up the screening. And this is as good as we get now with the most recent big data. You can see now there's nearly 18% polygenic prediction. That's still not good enough, but there's some kind of opportunities here that you can improve it a bit. But I think in these papers from the big genetic consortia, we say you should not use this data for prediction of individuals. And there are some out there, some private companies, they are misusing these data to offer services for individuals. That is very important that we in the mental health field really inform our patients, user groups, that to recommend not doing this. But there are some other examples where this is possible, to combine genetics, imaging, and clinical information, and that is in Alzheimer's disease. There are different opportunities in different countries. In Norway, psychiatrists see, in old age psychiatry, we see many people with dementia, or it's hard to differentiate between that and like depression. So the point here is, can we then identify people with late onset Alzheimer's disease? And we have now, as I showed, many variants, genetic variants, and you can use the kind of supervised machine learning and everything. But the point with Alzheimer's is it's not case control, if you get it, but when. So we have shown that, and it's obvious, if you live to 100 and get, or 105 and get Alzheimer's disease, that's quite different from getting when you're 75. So, and also with the timing, if you get, when you can start detecting the disease, when you have too much neurodegeneration, then there is no treatment that will work. But in the early phase here, before you have severe illness, then it's possible that the new drugs that are coming now can have effects. So that's why we have not only a polygenic score, but a hazard score predicting age of onset. So, and there are tons of papers now where we have discovered genetic factors for Alzheimer's. All the new drugs, there are many here now involved in this. They have been approved, the newest one in the US, but not yet in Europe, because there are side effects. And that's also really important. If you want to put people on a drug, you need to make sure it's early enough to have an effect, but you should not put people on these drugs if they're not really getting Alzheimer's disease. So then the use case could then be a memory clinic. People come to your hospital or outpatient clinic because of memory complaints. And then it's very important then to make sure, will they develop Alzheimer's? Could they be in the position to start these new drugs? And then genetics is not good enough alone. is it possible to combine several of these multiple markers? It could be imaging, as we heard about, genetics, but also clinical data. It's, either you genetics and only that, but no, you should combine these different data, like you showed earlier here. Paolo showed clinical information as quite important in early psychosis. So we combine these type of data, put them into the model and see, if you come with a memory complaint, will you develop Alzheimer's disease? That's a highly relevant clinical question. And then we put them all into this model, and then you can see here is when you come to the clinic, and then after 5 years, who developed disease. And just by genetics, you can see there is these with the lowest risk. There's only like 20% who developed Alzheimer. Here with the highest, it's like only 20% that did not develop. And then we were discussing here about explaining or how can you understand this. This is odds ratio, the 20% highest versus the 80% lowest, and there's a 3.5 increase. That is borderline, it cannot be used in a clinic. So genetics alone, not used in Alzheimer's disease. Okay, what will happen then? When you come to the clinic, you do imaging. That is done, at least in many clinics in Europe. Then you see there's a larger spread. The prediction is better than these multimodal. You can see these that don't develop disease are much more separated. And then the odds ratio is now 13. And people with high risk, they are really, most of them will get, we know that they will get Alzheimer after 5 years. So we can predict into the future. But then there's one more thing that people do in the clinic. They do cognitive testing. That's a clinical assessment. And then you really see a large spread here from nearly pretty sure that people here are not developing disease. And this you know here. And you don't need to put efforts, you don't need to do intervention or follow them. Here we don't need much interventions, but here, with these people here, it's much more likely. So here, even though there are unspecific symptoms in the beginning, start treatment. So this is really a way to put all these new precision medicine tools into action. And for running clinical trials, that is both in Alzheimer's, it's super expensive, but also in other field of psychopharmacology. And by adding these in prediction or enrichment, you can reduce the relative sample size to 30%. So the cost of running new trials, it's much smaller when you add these prediction tools. And this was also something that Paolo talked about. You can have all kind of hand waving and genetics and imaging and cognition, but how can this help the clinicians, the people with the families? So that's why we're in this EU project, we're developing some kind of portal to integrate this information, because it's impossible for clinicians to analyze 20,000 genetic variants or imaging or complex data. And then you integrate all the information, cognition, imaging, genotypes into a portal and get a risk report that can help design the treatment and management. So this is Alzheimer, but what is the opportunities like in bipolar disorder? And we're using the same approach there. This is very preliminary data, but you can say that, okay, if you add all the kind of multiple genetic variants with the imaging variants, this large-scale treatment, you can see that the area under the curve here, when you combine them, is increasing. It's not yet, as Paolo said, up there where you can act on it. It's not clinically relevant, but this is promising also in bipolar disorder. And then we can develop these cockpits also for bipolar disorder, integrating all this information. So I just want to thank all the participants in these studies. You know, there are hundreds of thousands of people generating data, and then also the funders. Thank you.
Thanks very much. So you talked about multimodal approaches, but what about multi-omic approaches and the role potentially for something like metabolomics, where it's already being applied in other medical conditions?
If you have the data, we can put it into the models. I think if it can help us predict, then we can use it. And I think there's a lot of potential now for blood markers, not only the specific ones, but you can screen for larger. But then it's always promising, but you need to train the model. You know, it's as long as it replicates and it can predict, then it's working. So we need to capture more of the variation.
So there's another question in the Slido that says, related to the low predictability of the current polygenic risks, it seems like the site consortium is going for massive samples. Would it be better to go for smaller sample sizes and make sure that the diagnosis is correct and focus on symptoms? So how do you take the large-scale data back down to the clinical level?
I think that's really important, what we are focusing now, and that's the beauty of the Nordic data. You have longitudinal information. What is happening first, when is disease developing, just like Paolo is doing in the clinical setting. And I think this is really important. But the problem is you don't have that fine-grained information unless you go into the real-world data. Clinicians in the hospital setting are generating this information. I think that is really where we need to go to, because yes, no, schizophrenia is a lousy clinical implementation.
That's great. Yeah, I think that's where the future is. Thank you very much. Okay, I'd like to welcome our final speaker, Claudia Pisano, also from the University of Cagliari.
Thank you very much. So it's a pleasure to be here to close this really exciting session on precision psychiatry and talk about the impact of sex and gender. So when we talk about the impact of sex and gender in health, in precision medicine and precision psychiatry specifically, we essentially talk about gender medicine, which can be described as a new dimension of medicine, focused on the study of how biological differences, so sex-related differences, or differences related to socioeconomic or cultural aspects between men and women, so difference which can be defined as gender-based differences, have an impact on our health. And this is not only the study of how men and women differ based on their clinical presentation, diagnosis, or response to treatment, but also, for instance, the study of differences related to pregnancy, to different physiological phases of the reproductive life of a woman. And these sex and gender-related aspects show complex bidirectional relationship. But the main challenge, as was already mentioned in some of the previous presentation, for instance, by Professor Manchia, is that when we think about drug development, essentially, historically, the approach has followed the one-size-fits-all model. And basically, drug testing has been conducted for many years predominantly on males, from preclinical research to clinical trials. So there is a landmark study published in 2009 that evaluated 10 different fields from biology to neuroscience and pharmacology, and found that there was an important male bias in the sex of animals used for preclinical research. And for some fields like neuroscience and pharmacology, the male animals were used 5 to 6 times more than female animals. And this situation has begun to improve, of course. But there is a follow-up study published in 2019 which compared these 10 fields and found that only for pharmacology we had a substantial increase if we consider not only studies that included male and female animals, but studies that actually consider sex as an experimental variable, so conducted, for instance, a sex-stratified analysis. And the result of this situation is that sometimes for different conditions, conditions, women who present with the same condition may receive a less evidence-based care. And there are several, we could say, myths or unsupported reasons for which this was the case for many years. For instance, we could think that female data will be more variable than male data, but this has been disproved by several meta-analyses, or that in order to include the female animals, we should test for all application these animals in all phases of the estrus cycle. And of course, this is not the case for most applications. But also, we could argue that some researchers argue that we tried to use male and female animals, we did not see any difference, and then we went back to using only males. But if we continue with mixed cohorts, the thing is that we can produce data that for now might not lead to identify significant differences. But as the research progresses, they could allow to discover, for instance, sex-specific mechanisms underlying the same outcome, so the so-called latent sex differences. And briefly, this was also the case for the participation of women in clinical trials. So basically from 1977 to 1993, women of childbearing age were basically excluded by FDA from most clinical trials, except for life-threatening condition. But now, of course, the situation is improved. We have different initiatives also calling for the inclusion of diverse groups of women in clinical research. And for instance, in Europe, we now have a regulation that came into effect in 2022, which states that we should justify the exclusion of people from clinical trials if we are going to use the drug in this group of people, for instance, based on gender and age. But this is relevant because for neuropsychiatric disorders, we notice several sex and gender differences, starting from incidence ratio. So we know that some disorders, such as major depression, have a higher incidence in women, and other disorders, such as schizophrenia and ADHD, have a higher incidence in men. But these are not the only differences that have been noticed. So some are related to clinical presentation or response to treatment. But the thing is that the biological factors underlying these differences are still actually understudied and poorly understood. So, for instance, some of these differences might be more related to gender factors. So, for instance, socioeconomic factors. In 2017, we studied the potential relationship between sex and the economic impact of anxiety disorders in the Psychohouse cohort, which is a population-based cohort representative of the city of Lausanne in Switzerland. And we found a significant interaction between sex and socioeconomic variables. And the main result was that among participants with anxiety disorders, only women were at higher risk of a lower socioeconomic status, of having a substantial debt, and having a reduction of income, supporting, for instance, the development of additional policies of support specifically for women with anxiety disorders. While other differences are more related to biological mechanisms. So we could think that the male and female brain are not so different on the global scale. But actually, if we conduct, and there are several studies now, conducted more fine-grained analysis, regional-based analysis, we can see that some differences can be observed, for instance, in regional gray matter volume. And importantly, these differences have been shown to be conserved from rodents to humans, and also coupled with differences in gene expression. And other differences have been outlined by studies using machine learning models on structural and functional brain imaging data to, for instance, study different brain phenotypes. One of the most interesting, in my opinion, is the so-called brain age gap, which is related to the fact that based on the imaging of our brain, we can compute an age based on our biological features of the brain. And we can compare this brain age with the age that we actually have, with our chronological age, to see if we are older or younger compared to what would be expected. And also for this phenotype, there were local differences based on the region of the brain that we used to compute this local brain age gap, suggesting also that fine-grained models have higher sensitivity to identify sex differences. We are conducted a study in which we are measuring a measure of biological age based not on brain imaging data, but on a peripheral measure on whole genome methylation measured in blood. And this study is including a patient with bipolar disorder treated with valproic acid, with lithium salts, and FE control. So we used all genome methylation data from these participants who were recruited at the unit of psychiatry and the lithium clinic of the University of Cagliari to compute a measure of their biological aging. And we found that this measure can be used to distinguish three clusters of participants. One, which is cluster 1, in which participants are actually younger than what would be expected based on their age. Again, an intermediate cluster, and the cluster 3, in which participants are older compared to their chronological age. And what we found, beside the differences between the patient and controls, consistent with the hypothesis that patients with a severe mental disorder show an accelerated cellular aging, so patients were actually overrepresented in this cluster 3. But what we found is that sex has a profound impact on this data. So from all of this red here, we can see that in cluster 1, so the cluster in which participants are younger from a biological point of view compared to their chronological age, we have a greater overrepresentation of women, while in cluster 3, most participants are males. And interesting work has also been done using data from the Psychiatric Genomic Consortium and the IPSIC Consortium as regard to sex differences in genetic predisposition to psychiatric disorders. So here we do not expect dramatic differences because the majority of twin studies did not identify substantial sex differences in the heritability of these disorders. However, it cannot be excluded that there are genetic variants that exert a sex-specific effect. And this study, which was recently published, actually found significant sex differences in the heritability of schizophrenia and major depression, not for bipolar disorder, and identified variants with suggestive sex-specific effect. And we are now leveraging this data to investigate whether there are sex differences in pleiotropy. So we now know that a genetic variance usually is not associated specifically with only one trait or only one disorder, but most genetic variants actually are able to be associated with different traits, and this is called pleiotropy. And there are now excellent methods, some of which have been developed by Ole's group, that can allow to study this pleiotropy in a very specific way, also taking into account variants that have a different direction of effect between the traits. And for instance, we found that if we study the genetic variants shared between schizophrenia and metabolic traits such as BMI, there are relevant differences between men and women in terms of specific genes which are involved and druggable genes, so genes that could be targeted by drugs. And similar results we observed when studying the genetic variants shared between major depression and chronic pain in either men or women. So the differences between men and women are also, might also be related to the interaction with the healthcare system and to drug prescription. A very relevant case is that of ADHD. So ADHD is, of course, more frequent in men, in male children, but actually the criteria used to diagnose ADHD have been developed taking into mind this prototypical patient, which is male. So there are now several studies confirming that female patients with ADHD are diagnosed much later and are less likely to be prescribed a medication for ADHD, even when the severity of symptoms is the same. So sex differences, when not taken into account, can also be associated with a delay in diagnosis or misdiagnosis, which I think is very relevant in terms of precision psychiatry. And I do not have time to go into much detail, but this can also be related to other drugs. For instance, in a meta-analysis in which we wanted to see whether there was any differences between men and women in prescription of opioids for pain control, we found that even when taking into account pain severity, women were less likely to be prescribed opioids for pain control, and especially women who had psychiatric comorbidities. So the very few slides at the last part of my presentation will be devoted to what we know in terms of different response to psychotropic drugs. There are several characteristics for which men and women are different based on body composition or expression of enzymes involved in drug metabolism that could imply differences in clinical response or adverse effects. But the thing is that we do not have a lot of data right now to see whether there are truly differences in clinical response or adverse effects. For instance, for antipsychotics, for adverse effects, it seems that some might be more frequent in women, but the number of participants included in this study, which are the most recent, are still, I would say, underpowered to truly identify relevant differences. For mood stabilizer, the most recent systematic review found that only one study per mood stabilizer could be included. And this study found no sex differences for lithium and better outcomes in male patients for the other mood stabilizer, while for adverse effects, all included studies were on lithium. So we are missing relevant data that could help to further understand the differences that could impact precision psychiatry as related to gender. And finally, for antidepressants, as we stated in a recent review we conducted, there are some reports suggesting potential gender differences in response, but no clear consensus. And specifically, we have no relevant ideas on the biological underlying mechanism. And I would like to briefly mention a project which was the PROMPT project funded by the IRA PERMED called, which I think will be of help to understand whether sex differences are relevant for antidepressant response, as this study was designed from the start to implement clinical, omics, but also sex-related data to develop an algorithm to improve the prediction of treatment-resistant depression. So to conclude, in this brief overview, I hope to have convinced you that there are several sex and gender differences that would be relevant to integrate in research aimed at improving precision psychiatry. And improved understanding of these differences is necessary to move us closer to the personalized approach that we wish to have. So I would like to thank you all for the attention and all the groups involved in this project.
Thank you very much. Very important topic and highlighted really some of the latest emerging differences. We have a couple of questions coming through. So one of the questions is whether or not you differentiated the women according to age related to pre or post menopause, but more generally, how would you modify your approach to what factors might matter from my perspective over the lifespan, right?
That's a very relevant question. So some studies actually took this aspect into account. Some studies did not find relevant differences in the sex and gender differences. So for instance, the study related to opioid prescription, even when taking the pre and postmenopausal factor into account, still found that women were less likely to be prescribed medication. But most studies do not report the data, so this is also a relevant aspect that should always be reported. The key message is that we should report the data. Then, if we are not able to conduct a sex analysis in our study, future meta-analysis will be fed with this data.
And do you have a recommendation for the metadata that you would recommend, right? So if people are working through these large products, what's the metadata that's missing from the public databases or the accessible databases? So
it seems strange, but sometimes we are even missing sex stratified data just at the level of the sex being reported, and this highly reduces the power of studies or the number of studies that can actually be included. So at the very least, let's report sex and gender and stratify the outcomes. Even if our study is not powered broad enough to actually conduct the analysis, I would say.
Okay, I'll ask you one more question. Does the sex difference in brain aging remain if we consider other risk factors for aging, like smoking, education, or other severe mental disorders?
So some studies actually take this into account. On the global scale, some studies do not find any differences, but on specific regions they do. So for instance, in our study on epigenetic brain age, we took these factors into account, and the differences are still striking, so they remain.
Great, fabulous. Okay, so thank you everybody for your attention, and thanks to the panel. I think it was a great session and a lot of interest. Anybody who had questions who happened to be in the room that we didn't get to, I'm quite sure the panelists would be happy to speak one-on-one as we close down the session. But enjoy the rest of your day and your meeting, and thank you.
Thank you.